Thank you, sir. Thank you to be here.
Good morning, everyone.
Hey,
Hey,
hi.
hi.
Can you hear me now?
Yes, hear me.
Yeah. Okay, sorry. Hi, good afternoon, all. This is Hannah again. And all of you, again, I'm welcoming you all to the next session. And a special welcome to our Mr. Termesh sir. So thank you, sir. Thank you to be here. And I'm handing over to Anusha ma'am to introduce our faculty.
Hi, good morning, everyone.
Good morning,
My
ma'am.
name is Anusha. I'm working as a head nurse at Sparsh Hospice. So, I'm your facilitator today. Today, our topic is management of pain too. The speaker is Mr. Terry. He is well-known person to us. So, Mr. Terry, he's completed BSc Nursing and MPH. He's a program manager, projects and advocacy in IAPC, and he is a national faculty also in IAPC, faculty for National Fellowship in Palliative Medicine by IPM and CMAI. And he is a PhD scholar, SRM School of Public School, and author of Home-Based Palliative Care Manual for Nurses. And
तो
he
मनोज
has
के
so
लिए
many
कल है ना
awards also.
तो मनोज कर दिया था
He
आपने क्या
is
कहते
a
हैं इससे
pioneering,
दुकान में तो है ही
featured as a pioneering nurses from around the
पानी
world
पिलाऊं
by St. Christopher's Hospice, and he got first prize in last year IAPCon 2025 for oral presentation. Welcome, sir. Welcome for today's class.
आंटी कितनी प्यारी लग रही है बहुत प्यारी
मैडम 1 सेकंड, ये जिनकी आवाज आ रही है एक बार म्यूट करवा दो उनको।
Teresa, are you here?
Hello. Yeah, sir. Now you can speak.
Uh, Dear participants, we have some network issues today. I think due to rain.
That PPT.
Hi everyone. So Mr. Terry will be joining soon. He has some network issues right now. So can we remind the previous class today?
Sister, am I audible now?
Am I audible? Yeah, Mr. Terry is here actually. Sir, am I audible?
Yes, you are audible. Can you hear me well?
Yes, sir.
Yes,
Sir.
yes,
You
sir.
can.
Okay. Sorry, I think some network issue on my side.
Okay. Now it's clear, sir.
Yes.
You can start, sir.
Shall I start?
Yes, sir.
Yes, sir.
Actually, just a minute. You can hold your mic. I'm going to introduce Mr. Terry. Last, due to some technical issue, we missed that introduction part. So, Mr. Terry, he's completed his BSc Nursing and MPH. He's a program manager, project and advocacy in IAPC, and also national faculty for IAPC, and faculty for National Fellowship in Palliative Medicine by IPM. And he is a PhD scholar and author of Home-Based Palliative Care, a manual for nurses, and uh, he got awards in pioneering nurses from around the world by St. Christopher's Hospice, and he got first prize in oral presentation in IAPCon 2025. So welcome, sir. Today our topic is pain management too. Please continue, sir.
Hannah, I've sent a request for screen sharing. If you could approve. Is my screen visible to all of you?
Yes, sir.
Yes, sir. Okay. Um, uh, Good afternoon, everyone. I'm very sorry for the network issue, and I think there was an unnecessary delay because of that. Let's try to catch up the time. Um, I believe someone else had already taught you about pathophysiology of pain and assessment of pain. So in continuation of that, I will be talking about management of chronic pain. So the session will focus predominantly on chronic pain. Um, Management of acute pain is slightly different, so many things are overlapping. But here I will be talking to you about management of chronic pain. This earlier session that we had before this session forms the basis for the management. Okay. When we talk about management of chronic pain, differentiating between nociceptive pain and neuropathic pain is of paramount importance. Okay, because the management is very different. The management of nociceptive pain is very different from the management of neuropathic pain. So that is one clear distinction we need to make before we start managing. The other important thing that we need to understand is the severity of pain. Okay. These two things are very essential for us to effectively and completely manage pain. Okay. So I am actually assuming that those concepts are very clear for you. The difference between nociceptive pain, neuropathic pain, how to differentiate them, how to identify when those two pains are overlapping, and also about the severity of pain. Okay. So I will move to my session proper. When we are managing chronic pain, predominantly what is seen in cancers, okay, we adhere to certain principles. Okay, these principles are by the mouth, by the clock, by the ladder, and by the individual. Okay, can any one of you say what by the mouth means? Please feel free to unmute or put it in the chat. What do I mean when I say by the mouth? No response. By the mouth, any response? Okay. By the mouth means as long as it is okay. I see one chat. See, okay, good afternoon. Okay. By the mouth means as much as it is possible, as long as it is feasible for the management of chronic pain, oral route is preferred. Okay, over parenteral route, which is your IV, IM, subcutaneous injection. We always prefer oral route of administration when we are managing chronic pain. Why is that? Why do we prefer oral route over parenteral route when we are managing chronic pain? See, when we are managing acute pain, let's say you had a fracture. Okay, you had a say a minor accident and you had a fracture, and the pain that you are experiencing is acute pain because of an acute injury. Okay, if you are developing a fracture, probably the pain will be very intense on day one, and the pain will go down on day two. By day three, day four, day five, the pain is more or less disappeared. And if there are any movements, we will get pain. That is how acute pain manifests. But chronic pain is not like that. Chronic pain is something, a pain that doesn't go away. Okay. You take an example of, let's say, there is a patient with carcinoma buccal mucosa. Okay, this is our buccal mucosa inside the mouth. Okay. If there is a tumor in the buccal mucosa, that tumor will be infiltrating into the buccal tissue. Correct? Okay. That is how malignancies normally behave. If the tumor is infiltrating into the buccal tissue, it is constantly causing a tissue infiltration or tissue injury. Okay. So the pain this person is going to experience is going to be a chronic pain, a pain that doesn't go away. As long as the tumor is there, as long as that infiltration is there, there will be pain. This is very different from acute pain because in a fracture there is healing. Even before the healing is complete, the pain disappears. But unlike in malignancy, the pain is going to remain because the tumor is going to be there unless we give a chemotherapy, radiotherapy, or a surgery to remove it. Okay. So when in the setting of a malignancy, the pain is going to be chronic because the injury is going to be lasting. Okay. The tumor is there infiltrating into the tissue. So day and night, light and day, this patient is going to have pain. And that is a hallmark of chronic pain, which is constant. Okay. So why do we prefer oral route? It is simply because, okay, if you are giving, for example, this patient has a carcinoma buccal mucosa and you are prescribing this patient tablet tramadol. Okay. Tramadol's half-life is around 6 to 8 hours. It will not work beyond that. So that 6 to 8 hours, this person's pain will be suppressed by the drug tramadol. But after the action of the drugs wears off, the pain will again come back. If you give this person diclofenac tablet, the duration of action is around 8 to 12 hours. That's the half-life. 8 to 12 hours, he may probably be comfortable. But after the 12 hours, the pain will come back immediately because the tumor is there and the injury remains. Okay. And that is why we prefer oral route. If you go for a parenteral route, according to the half-life of the drug, if it is tramadol, you may have to give 6 to 8 hours. So 4 times a day or 3 times a day, you will have to give an injection. If it is diclofenac, you will have to give twice a day injection. And this is going to be a very long time thing. And many patients with malignancies, okay, are diagnosed in India per se. Many patients with malignancies are diagnosed at the later stages. Okay, that means their malignancy is more or less incurable. Okay, so they are going to constantly have pain because of their malignancy. So you cannot keep giving injection every day, multiple times a day. Okay, it is not feasible, it is not practical, neither it is convenient. Okay, that is the first principle of pain management by the mouth. Okay, as long as it is possible. Okay, if it is not possible, we switch over to parenteral. But when it is, if it is possible for the patient to swallow the drug, we prefer oral route because we can give the oral drug conveniently. And one another issue is in palliative care setting, we use a lot of opioids. Okay, strong opioids like morphine, methadone, fentanyl, and all of these opioids, especially morphine, when it is administered orally, it is very safe, very, very safe. Okay. Unlike when it is administered parenterally, the side effect profile significantly increases when it is administered parenterally. It is not that it is dangerous, okay? When it is used rationally, it is still safe. But in comparison with oral morphine versus IV morphine, oral morphine is much, much safer because when we give opioids orally, the plasma concentration increases very steady. Okay, oral morphine takes about 30 minutes for the plasma concentration to peak. So the steady rise, okay, prevents a lot of adverse events. Unlike when you give morphine IV, the plasma concentration rises within 5 minutes. Okay, there is a peaking of plasma concentration. Okay, so that is where you get to see a lot of problems. So as long as it is possible, as much as it is feasible, prefer oral route for managing chronic pain. That is number one. Second principle is by the clock. By the clock means in the management of chronic pain, we do not prescribe drugs as and when it is needed. That is a wrong way of managing chronic pain. What do I mean by that? As I said, chronic pain means a pain which is going to be there throughout unless and until you remove the disease, which is in palliative patients with palliative care, it's just usually not very much possible. The pain is going to remain. Okay. So the pathology we are not able to modify, but pain suppression we are able to do. And this pain suppression should be constant. So the prescription or the drugs are provided by the clock. What do I mean by that? As I said, according to the half-life. If it is tramadol we are giving it every 6 hours or every 8 hours, because we know the half-life of tramadol is 8 to 6 hours, 6 to 8 hours. Okay. So if the patient is getting tramadol, for example, if the prescription is tablet tramadol Q8 hourly plus SOS dose, you will have to give according to the time and not wait for the pain to come back. Okay. Today morning, patient took tramadol. The next dose comes in the afternoon. Patient was completely fine, comfortable till the afternoon. Then you think, okay, patient is pain free. I will skip the next dose. Don't do it. If you skip, pain will come back. Okay, that is the characteristic feature of a chronic pain. We do not wait for the pain to come back, but according to the time of the duration of the action of the drug, we keep giving the drugs and constantly we suppress the pain so that patient's pain doesn't come back. In between the doses, if the patient needs additional dose, we can give a SOS dose or rescue dose. That is different. But the dose that is needed according to the time should be given by the clock. Okay, whether patient has pain or not, according to the time, you should keep giving the drug. Okay, that is by the clock principle. Next, by the ladder. By the ladder means WHO analgesic ladder. Okay. WHO analgesic ladder is a very simple, straightforward process. I will show in the next few slides. Next is by the individual. By the individual means the need for the drug and the dose titration should be based on individual response. Okay. What do I mean by that? For example, let's take there is a patient who is coming to you with severe pain. Okay, when you assess this pain, I hope how to use NRS scale was taught in the earlier classes. When you assess the pain using the numerical rating scale, the patient is scoring his pain as 9. Okay, that is very severe pain. Now, for the score of 9, okay, according to the WHO analgesic ladder, you should ideally start the patient on strong opioids like morphine. Okay. Now, let's say this patient, you have given the prescription tablet morphine 10 mg Q4 hourly. Okay, plus SOS dose. Now, this patient, after receiving 10 mg morphine, he is comfortable. Now, there's another patient who is coming to you. Now, he is coming to you and he's telling his pain score is 7. Still, he is falling under severe pain category. Okay, 7 to 10 is severe pain category according to the numerical rating scale. Earlier, the patient had a score of 8, so you started him on morphine. Here also, he has severe pain, which is 7. Now also, you are starting him on 10 mg morphine. Okay, but this patient is telling, I don't have pain relief with 10 mg morphine. That means you will have to escalate the dose. You should not think, oh, the earlier patient, he had score of 8, 10 mg work, but he is only 7. 10 mg is not working. I will not increase the dose. No. According to the individual's need and the response to pain, you will have to titrate the dose. Okay. Just because 10 mg worked in one patient does not mean 10 mg will work in another patient. You will have to titrate the dose according to individual's need. These are the main principles of pain management, which is by the mouth, which is giving drugs orally, by the clock, which means giving the drug according to the time, irrespective of whether the patient has pain or not. You should not skip a dose just because patient does not have pain. If you skip a dose, pain will come back because we are dealing with chronic pain. Next is WHO analgesic ladder, which means we follow the 3-step process, which I will explain later. And by the individual means you are titrating the dose according to the response for pain. Okay, not according to some common category that you have. Okay. WHO analgesic ladder is a very flexible protocol. Okay. It has very simple 3 steps. Sir, explain third point one more time. What is this? You mean by the ladder? By the ladder, I will be explaining now. I didn't explain here because it is a little long process. I will be explaining it now by the ladder. Okay. This is what I'm going to do. This is WHO analgesic ladder, and this is what I'm going to explain. This WHO analgesic ladder has only 3 steps. Okay, each step we use different kinds of drugs. Okay, according to the severity of pain. Okay, there are, as I said earlier, there are only 3 steps: step 1, step 2, step 3. Okay, step 1 we use for mild pain, step 2 we use for moderate pain, and step 3 we use for severe pain. Okay, if it is mild pain in the NRS it is between 1 to 3. NRS score of 1 to 3. Moderate pain is 4 to 6. Severe pain is 7, 8, 9, and 10. Okay, so just simple 3 steps. So there are different type of drugs that we use in each step, and that is what I'm going to explain now. Step 1. Okay, prescribed for mild pain. Okay, what are the drugs that we use? NSAID. The main group of drugs that we use in step 1 is NSAIDs. NSAIDs, non-steroidal anti-inflammatory drugs. Okay, this NSAID can be clubbed with paracetamol or without paracetamol. Okay, paracetamol, though it works like NSAID, it does not have many problems that are there with NSAIDs. For example, paracetamol doesn't cause gastritis. Paracetamol doesn't cause renal impairment. Okay, so though it works like NSAIDs, but it is not a typical NSAID. Okay. Can you give me some examples of NSAIDs? Can you unmute and tell? NSAIDs?
aspirin, ibuprofen.
Very good. Aspirin, ibuprofen. Good. Anything else? Okay, diclofenac, aceclofenac, aspirin, ibuprofen, meloxicam, naproxen, celecoxib, itoricoxib. There are several NSAIDs. Okay, any one of the NSAIDs will do. That what kind of NSAIDs that you choose will be based on patient's history. For example, if you are having a patient who needs step 1, and the patient has a history of coronary artery disease, you will not use diclofenac. Diclofenac has the highest potential to cause a coronary event. Okay, you will not use diclofenac, rather you will use naproxen under 1000 mg per day. Okay, which is considered safe in patients with heart disease. So different, if the patient has a renal impairment, you will not use any NSAID. Okay, so which NSAID to choose will depend on patient's characteristics. Okay, so for mild pain, we use NSAID. One very important thing you need to remember is that when you're using NSAID, you should use only one NSAID at a time. Okay, no two NSAIDs in the same prescription. If you use two NSAIDs, it is going to seriously increase the side effect profile. Patient will come back to you either with a severe gastritis, bleeding issues, or renal impairment. Okay, only use one NSAID in a prescription. Okay, that is very, very important. If you feel NSAID is inadequate, you can add paracetamol. As I said earlier, paracetamol, though it works like an NSAID, it doesn't have problems that are usually seen with NSAIDs. Okay, so paracetamol you can add with an NSAID, but only one NSAID at a time. Okay, when you are using NSAID, which is step 1, you should always use a proton pump inhibitor. Okay, which is either in omeprazole or pantoprazole. Okay, you should give a very clear advice to patients. You should tell the patient in the morning when you get up, take this omeprazole tablet in empty stomach. This omeprazole tablet will help in suppressing acid in the stomach. Then you have your meal, your breakfast. And after having your breakfast, you take this pain medicine, which is an NSAID. Okay, NSAID should never be taken on empty stomach. Okay, NSAID can greatly inhibit prostaglandin synthesis, which are protective in the stomach to balance the acid. So, so that is why we suppress acid with a proton pump inhibitor. And keep in mind, proton pump inhibitor should be taken empty stomach. Okay, and NSAID should be taken after meal. Okay? Very clear advice should be given to the patient. Okay, and monitor the patients for renal toxicity and bleeding issues because NSAIDs are known to cause both. Okay, that doesn't mean they should not be used. Okay, monitor them, and when you're monitoring them, if you're catching it early, you can stop the NSAIDs because in chronic pain management, all these drugs we will use for a long time. Okay. Any doubt in step one? And keep in mind, if one NSAID is not working, there is no point in switching to another NSAID. Okay, efficacy of these NSAIDs for managing chronic pain is more or less the same. Okay, okay, you started the patient on diclofenac and added paracetamol. Patient is not having adequate pain relief. Don't stop diclofenac and add aceclofenac, or don't stop diclofenac and take say naproxen. It will not. If diclofenac is not helping, naproxen will also not help. If the patient is having inadequate pain relief with step 1, you need to move to step 2. Okay, that is you are going up the ladder. Always remember like this: in a ladder, in a physical ladder, you cannot move sideways. You can either go up or down. So switching between NSAIDs is not helpful. Okay, if step 1 is not working, go to step 2. Okay, adjuvant drugs I will explain. Okay, in the end I will explain. Okay, if there is no relief with step 1, go to step 2. Or if the patient says he has moderate pain, go to step 2. Step 2, moderate pain, numerical rating scale 4 to 6. Okay, step 2, you can either prescribe only step 2. Okay, step 2, we have most commonly used drug in step 2 is tramadol. In step 2, we use weak opioids. Okay, weak opioids. Weak opioids like tramadol or codeine. Okay, we also have a fairly new drug in India called tapentadol. So that is also a weak opioid. So they work like opioid, but they do not have the potency of strong opioids. That is why we call them weak opioids. Okay? But they are much stronger than NSAIDs in suppressing pain. So in step 2, we use weak opioids. Either we use only step 2 or we club step 1 and step 2. That means a patient can have tablet tramadol 50 mg Q8 hourly plus SOS as a single prescription, or he can have tablet tramadol 50 mg SOS, 50 mg Q8 hourly SOS with tablet diclofenac 50 mg BD, tablet paracetamol 650 mg Q6 hourly. All three can be there in the same prescription. Okay, so step 1 can be clubbed with step 2. Okay, so you can club NSAID, paracetamol, and a weak opioid like tramadol to get co-analgesic effect. Co-analgesic effect is all these pain medications will help one another in suppressing pain. NSAIDs will suppress inflammatory pain. Okay, weak opioids will suppress pain along the central pathways. Okay, so we have one drug working on the peripheral pathways, another drug working on the central pathways. Okay, so step 1 and step 2 can be clubbed together for superior analgesia. So step 2, we have most commonly used drug in step 2 is tramadol. Tramadol, we get a 50 mg capsule or a 50 mg tablet. Maximum dose of tramadol per day is 400 mg. Okay, we will not go beyond 400 mg. If the patient is on tramadol, the prescription is like this: tramadol 50 mg Q6 hourly. That means he is getting 4 doses per day: morning, afternoon, later in the evening, and later in the night. Okay, 4 doses per day as regular dose. You can tell the patient they can take additional 4 doses as extra. 50 mg tablet, 4 doses per day is 200 mg per day. I said tramadol maximum doses 400 mg per day, which means this patient can take additional 4 doses in case in between he gets pain. Okay, but if the patient is crossing 200 to 300 per day, It is a very clear sign that you need to move to step 3. Okay, this is how we will understand when the patient requires morphine or not. If you are carefully titrating, you know that every day this patient is taking 2 or 3 doses extra because his pain relief is inadequate. Then we switch to step 3. Most importantly, there is no step 2 in pediatric age group. Tramadol we will not use in pediatric age group. Tramadol lowers the seizure threshold. Children can quickly develop seizures. They are very prone to seizures. A small fever, children can have febrile seizures. So tramadol can complicate all those. Okay, so we don't use tramadol in children. Codeine is another weak opioid which can be used, but the problem is in some children codeine will not work for pain relief. So for all practical purposes, there is no step 2 in children for pediatric age group. So for pediatric age group, from step 1, we will directly go to step 3. Okay, is that clear? Okay, just like in the step 1, I said use only one NSAID at a time. In weak opioids also, you should use only one weak opioid at a time. Okay, if you use 2 weak opioids at the same time, there will be increased drowsiness because the side effect profile significantly increases. Okay, coming to step 3. Step 3, we use strong opioids. Very important thing you need to remember is when you are moving from step 2 to step 3, discontinue step 2. Step 2 should be stopped. Then you should start step 3, which means the patient is on tramadol, discontinue tramadol and start the patient on morphine. Why? Because they work in a similar mechanism. Weak opioids and strong opioids normally bind to similar receptors. Okay. So if you give both the drugs together at the same time, both the drugs will be competing for the receptors. There will be a lot of free drug in the circulation, which will go attached to other receptors and patient will be very drowsy. Side effect profile will significantly increase. So when you are moving from step 2 to step 3, stop step 2, but you can continue step 1. They work by a totally different mechanism. Okay. NSAIDs are working on the peripheral pathways. They suppress prostaglandin synthesis. So they suppress inflammation. Okay. Opioids works on central pathways. Okay. So step 1 and step 3 can be clubbed together. It is correct. Step 1 and step 2 can be clubbed together. It is correct. But step 2 and step 3 cannot be clubbed together. Weak opioid and strong opioid you cannot give together. Okay, you need to stop a weak opioid, then start the patient on a strong opioid. Okay, this is WHO analgesic ladder. Okay, any doubts in this WHO analgesic ladder, we can discuss and then we'll move forward. Any doubts, questions?
सर अगर जैसे हम NSAID की बात कर रहे थे उसमें एस्पिरिन
Sorry,
भी आता हेलो
can you speak? Can anyone translate that? I don't understand Hindi. I'm very sorry.
ओके सर सर फर्स्ट स्टडी NSAIDs group in NSAIDs group aspirin is also included
Yes,
now
correct.
now patient is suffering from bleeding tendency so aspirin is given or not.
No, we don't use aspirin. We use another NSAID that doesn't interfere with platelet function. That is
Okay
why
sir.
I said no. Which NSAID you choose depends on the patient's history. If any, see, if you want, you can go much deeper, which may not be, within the scope of this class. There are COX-1 select, COX non-selective, COX-2 selective. Okay, so based on that, we can choose. Okay, that will be a very complicated diagram if I start that, and most of the time will be spent on that. There are NSAIDs, okay, that does not interfere significantly with platelet function. Okay, one NSAID that doesn't interfere significantly with platelet function is diclofenac. Okay, but then diclofenac has higher cardiac side effects. So we don't use diclofenac in patients with heart disease. Okay, in that way, naproxen is much safer. Okay,
Yes, sir.
Ibuprofen within 1200 mg per day is safer in patients with heart disease.
Yes, sir. Thank you.
And no NSAID is safe in patients with renal impairment. Okay. So you
Yes, sir.
should not use any NSAID for a patient with already compromised renal function.
Okay, sir. Thank you.
Okay. There's a question on what is the maximum dose of morphine per day. I will come to it little later. Adjuvant drugs. Okay. I will show now. Thank you. Are you able to see my screen?
Yes, sir.
I'm not able to move it.
You're asking about the PPT only, Anna, sir?
Some PPT is stuck. 1 minute. Okay, let me just
Okay.
restart. Can you see it now?
Yeah, yes, sir.
यदि 2275 जी पर चलो इसका
Someone needs to mute. Okay, thank you. So these are the commonly used drugs in each step. Step 1, step 2, and step 3. Okay, I have highlighted the ones that are most commonly used. Most commonly used in step 1, paracetamol, ibuprofen, diclofenac, meloxicam. Okay. Step 2, most commonly used is tramadol. Okay. If you are really practicing working in palliative care center, you don't have to learn about all these drugs. Just one the highlighted, you can learn more. That will be very useful. Okay. Step 3, most commonly used is morphine. Okay. Most commonly used, most safest, and also the cheapest. Okay. Morphine is really a big blessing for patients with palliative care needs. Okay, now we come to adjuvant drugs. What are these adjuvant drugs? Adjuvant drugs are the drugs that help with pain management but does not have a direct pain reducing mechanism or property. They reduce pain indirectly. For example, a patient with very severe gastritis, he's going to come and complain saying that he's having burning pain in the stomach or stomach pain. So will you just give him an analgesic to suppress that stomach pain? No, it will not work. You know that gastritis is it can be managed by suppressing the acid. So you give proton pump inhibitor, PPA, like omeprazole or rabiprazole, and his gastritis pain will disappear. Similarly, laxative. Okay, when the patient is on morphine, morphine is notorious to cause constipation. Okay, when the patient is constipated, he is going to have abdominal pain. Will you give another drug for abdominal pain? No. You only need to give him laxatives. Laxatives, when constipation is relieved, pain will also be relieved. Okay. We have corticosteroids. Corticosteroids usually some in neuropathic pain when there is a tumor growing and pressing on the nerve, we give them corticosteroids. Why? There is usually a swelling around a tumor, and usually it is the swelling that is causing a lot of compression. Corticosteroids will reduce the swelling. Okay, so the compression will reduce. Okay, and the pain will also reduce. So it is very useful in patients with neuropathic pain. Similarly, we have antidepressants, muscle relaxants. They are all reducing pain through indirect mechanisms. Antidepressants, anti-epileptics, antidepressants like amitriptyline, anti-epileptics like sodium alpha, they are all very useful in neuropathic pain. When a patient is having severe muscle spasm, he will have very severe pain. No matter how much morphine you give, it is not going to work because muscle spasm is resistant to opioids. Okay, you need to give muscle relaxants. Okay, one of the very cheapest and long-acting muscle relaxant is diazepam. Okay, so these are all what we call adjuvant analgesics. They don't have direct analgesic property, but indirect mechanism they reduce pain. Okay, this is about adjuvant analgesic. Okay, now I'll go to morphine. Okay. Okay. Now I'll talk a little bit more on morphine. Morphine, when you are giving morphine, oral route is one of the best ways to give morphine. Why? Oral route is very safe. Okay. As I said, no, when you are giving morphine orally, the plasma volume increases very steadily. It doesn't peak suddenly. So that greatly reduces the potency of a untoward or adverse event. Okay. And oral, when you are giving morphine, whether you are giving it IM or IV or subcutaneously, morphine's half-life is only 4 hours. Okay, which means morphine will work only for 4 hours. Okay, only for 4 hours. It won't work for more than 4 hours. Your kidneys will quickly excrete morphine. Morphine is metabolized in the liver and excreted by the kidneys. Okay, your kidney will very efficiently push out morphine. Okay, that's its work. Okay, so morphine works only for 4 hours. So if the patient is receiving morphine for chronic pain, you need to administer it every 4 hours. Okay, you need to administer it every 4 hours. If you give morphine BD for a patient on chronic pain, it is irrational. If you give morphine TID for a patient with chronic pain, it is absolutely irrational. After 4 hours, the patient will have pain because the patient is experiencing chronic pain. See, in acute pain, morphine is not given like this. Okay. But in chronic pain management, you need to give it every 4 hours. By the end of 4 hours, patient will get pain once the action of morphine wears off. Okay. And there is something called double dose in the night. I'll just explain that. Where is the whiteboard? Okay, can you see my white screen? Is my white screen visible to you?
Yes, sir.
Okay.
Yes,
Let's
sir.
assume, let's assume this is a patient with a morphine prescription, tablet morphine. Okay, 10 mg, Q, 4th hourly. Okay, always PRN or SOS doses always written along with it. Okay, let's say this patient starts taking morphine. Usually, this is what we recommend. 6 a.m. he takes 10 mg, which is one tablet. Okay, sorry, 10 mg, one tablet. Okay, when is his next dose? 6 a.m. he has taken 10 mg. When is his next dose?
10 a.m.
Anyone? Very good. 10 a.m. Again, he takes 110 mg according to the prescription. If not, if he skips the 10 a.m. dose, pain will come back, definitely. Okay, we are dealing with chronic pain. Okay, so 10 a.m. he takes one dose. Okay, one tablet. Okay, now, when is his next dose?
2 p.m. 2 p.m.
2 p.m. Very good. 2 p.m. he gets his next dose. 10 mg, one tablet. Okay, now when is his next dose?
6 p.m.
Very
6
good.
p.m.
6 p.m.
6.
6 p.m. he takes another 10 mg. Okay,
One tab.
tablet. Okay. When is his next dose?
10 p.m.
10 p.m.,
10
sir.
p.m. 10 p.m. One tablet. When is his next dose?
2 a.m.
2 a.m., sir.
2 a.m. 10 mg. One tablet. Do you see a problem here? There is a big problem. See, for a patient with chronic pain, sleep is very, very important. Okay, we always see this. When the patient sleeps well, the next day his pain relief is much better. Okay, If there is one book by Dr. Twycross, okay, this is how he prescribes pain management approach. First, patient should sleep well without pain. Next, after that you have achieved, next the patient should be able to rest well without pain, usually achievable. The next step is patient should be able to do some activities without pain. Okay, sleeping is very essential for chronic pain management. But here, if you are waking up the patient, giving morphine and let him go back to sleep, that is very, very bad. Not practical. Okay. Okay. So what do we do? The 2 a.m. dose we'll give at 10 p.m. itself. Okay. Okay. It works by the principle of half-life. No, I said it works only by 4 hours. Why 4 hours? By 4 hours, your plasma concentration will become half. Because you are doubling the dose at 2 a.m., that 20 mg will become 10 mg, which is actually what patient needs. Patient may be slightly be drowsy because you are giving double dose in the night, but anyway, he's going to sleep. So it is not a problem. So 10 p.m. we give him double dose. But even when you give double dose at 10 p.m., some patients I've seen, they complain, get up with pain at around 3 a.m. or 4 a.m. or 5 a.m. That pain relief doesn't last all the way to 6 a.m. For some patients, it may last till next to 6 a.m. in the morning. Okay. So that should be managed. Okay. Is this clear? The principle of double dose in the night, is it clear?
Yes, sir.
Okay. Now, there is another thing. Okay. 6 a.m. patient, you have given him morphine. Okay. 10 mg, one tablet you have given. Okay. Now, at 8 a.m., he is having pain. What will you do? Anyone? There is this SOS, no? There is always a standing order when the patient is on morphine. So
Yes,
what will
sir.
you do? So what will you do? 6 a.m. he has pain. He took his regular tablet, but before 10 a.m. where his next dose comes, at 8 a.m. he's having pain. What will you do?
Sir, I think half dose of given जैसे 4 mg है तो 200 mg.
Okay. So for a patient with malignancies, there is no business of half dose. Okay. SOS dose is always equivalent to the regular dose. So at 8 a.m., we give him 10 mg, one tab, because he had something called, this is what we call breakthrough pain. When you are keeping a patient on an opioid to suppress his chronic pain, occasionally the pain will shoot up in between. Okay. And that is what we call as breakthrough pain. How do we manage this shooting up pain? Again, we'll give one extra dose and suppress that pain. Okay, that is what we did. And the rescue dose or the SOS dose is always equivalent to the regular dose. Is that clear?
Yes, sir.
Okay. Now we have given one extra dose at 8 a.m. Okay. So what will you do at 10 a.m.? Next, his regular dose is coming. Correct? Okay, this is an extra dose. So what should you do with the 10 a.m. dose? Should you give or skip it?
सर skip करेंगे.
Okay. You remember the principle of by the clock. Never skip
We have to give
regular
it.
dose.
We have to give the
Okay.
regular dose, sir.
Regular dose should never be skipped. Okay. Even if you give this at 9 a.m., you should still give this 10 a.m. dose. Regular
Yes.
dose is never skipped. Okay.
Okay.
Regular dose should go according to the time. According to the clock, it will keep going. Okay. No change at all. So 10 a.m. dose, you will have to give. Clear?
Yes, sir.
Okay. Now 10 a.m. you gave his regular dose. Now at 1 p.m. patient is complaining of pain. 2 p.m. his next dose is coming. 1 p.m. he is complaining of pain. What will you do?
So we'll repeat 10 mg again
10 mg,
Yes.
1 tablet again.
Okay, rescue dose 10 mg, 1 tablet you should give. Okay. Now, what about 2 p.m. dose?
We
2
have to give it,
p.m.
sir.
regular dose.
Okay, don't skip regular dose. Go
Yes.
according to the regular dose. Now, 2 p.m. to 6 p.m. no problem. 6 p.m. to 10 p.m. no problem. Okay, somewhere at 3 a.m. patient is having again another breakthrough pain episode. What will you do? 10 p.m. he took 20 mg. Okay, double dose. And you expect the double dose to last till 6 a.m. But at 3 a.m. he's getting up with pain. Again, what will you do?
The same 10 mg, one
10
tablet.
mg, 1
Yes,
tablet.
sir.
10 mg, 1 tablet.
One tablet.
Tablet.
Okay,
We will
rescue
give.
dose is always equivalent to the regular dose. Okay, now, okay, now look at this. This patient took 60 mg as regular dose, correct? Plus 30 mg as
30 mg.
Yes,
Yes,
sir.
yes.
rescue dose. Is that clear? See,
Yes,
10
sir.
Yes, sir.
mg, 20 mg, 30 mg, 40 mg, plus 2, 60 mg,
60
correct?
mg.
That is regular dose. 10 mg, 10 mg, 10 mg, 30 mg as rescue
As
dose.
restored.
Okay. This
Okay,
is
sir.
your first day observation. Okay. Second day also at different points he took 3 rescue dose. Third day also at different points he took 3 rescue dose. So this means, okay, you know that this patient needs 90 mg morphine per day. So what do? Next day, you change his prescription as tablet morphine 15 mg Q 4th hourly plus SOS. Okay. 15 into 6 is how much?
90.
This is how I calculated. That 90 mg, I divided it to 6 dose because we are giving every 4th hourly, no? Every 4th hourly if you give, which means 6 times a day. Only thing we are double dosing in the night. Okay. So this patient will get 4th hourly starting at morning 6 a.m. 15 mg, morning 10 a.m. again another 15 mg, afternoon 2 a.m. 2 p.m. another 15 mg, evening 6 p.m. another 50 mg, and before sleep in the night he takes 30 mg. Okay, this is how we titrate. Okay, if the patient is generally having inadequate pain relief, we usually increase the dose by 50%, which will also be more or less the same. Okay, is this clear on how to titrate morphine?
Yes, sir, but maximum dose क्या रहेगी?
Yes, sir.
What will be the
No,
maximum dose we can
no
give per
max.
day?
Yes, I'm coming to that. Okay, morphine doesn't have ceiling effect. Okay, morphine has no ceiling effect, which means for morphine, okay, there is nothing like this is the maximum dose per day. As long as the patient has pain, you can keep increasing the dose of morphine. We have had patients with almost 1200 mg morphine per day. He lived for a very long time. Okay. It came in the newspaper and all, okay, in Kerala. So morphine doesn't have a ceiling dose. As long as the patient has pain, morphine is safe. The morphine that you give will be utilized to suppress the pain. The problem will come when you give the dose more than the patient requires. Okay. Let's imagine a situation you are giving morphine. Okay. Patient requires say 15 mg and in titration you made it 20 mg. What will happen? First sign of overdosing morphine is patient will become drowsy. Okay, patient will become drowsy. Okay, when the patient becomes drowsy, okay, you know that patient is be getting morphine more than what he requires, so you bring down the dose. Okay, you will clearly know. Okay, so as you increase the dose, the drowsiness will also keep increasing. Okay, usually the practically clinically this is what we see. Okay, if you have slightly increased the dose more than what patient needs, patient will complain to you that he is feeling a bit sleepy. That is one stage of drowsiness. You are not very attentive and you missed it. Okay, and that higher dose continues or you have slightly even more increased. Patient will be talking to you, and while talking to you, he'll just doze off like this. Okay, we are clear. This is when we morning when we review, no, this is what happens. We'll be talking to you, and then he'll be sleeping in between. You know that patient is getting higher dose than required. Even then, if you miss, what happens? Patient will be completely sleeping on the bed. But you wake him up, he will get up. And then he will respond, he will go back to sleep. He will not be able to control that drowsiness. That is much little more higher. Extreme drowsiness is patient is in a deep sleep where you are not able to wake him up. Okay. And even then you keep increasing. See, at this point, patient is not able to take the tablet by mouth. Practically you cannot give. So it will actually come back to normal. Okay. Problem will come when the patient is on NG tube and the caregiver missed it and then gives this. So the distance between extreme drowsiness and respiratory depression is very long when you are giving morphine orally. Okay, that is why practically with oral morphine, you don't see respiratory depression as a, which is a serious side effect or a serious toxic effect with oral morphine. So the distance is quite large. So you will know, definitely you will know that you are overdosing the patient. Okay. Morphine doesn't have a ceiling effect. If the patient is in pain, all the dose that you give will be used up for suppressing the pain. Okay. So tramadol has a ceiling effect, which is 400 mg per day. Diclofenac, 150 mg per day. Paracetamol, 3 to 4 grams per day. Okay. Morphine, no ceiling dose for morphine. As much as patient needs, you can increase as much as the patient needs for his pain management. Okay. Any doubts? Any doubts? Any questions? This question was asked by Jyoti, right?
Yes, sir.
Jyoti, is that clear about a maximum dose of morphine?
Yes,
No
sir.
maximum dose per day. No
Yes, sir.
ceiling effect.
Yes, sir. It is clear. Thank you, sir.
Okay. I will talk about side effects and toxic effects of morphine and then we will stop. Okay. Morphine, though it is a wonderful drug, though it is very useful drug in patients with palliative care needs, it is notorious to cause constipation. That is one of the most difficult side effects of morphine. Okay. Morphine will surely cause constipation for two patients. So, how do we prevent constipation? Even as we write morphine prescription, we also write a prescription for a stimulant laxative. Okay. It is not any laxative. Okay. We have different class of laxative. We have stool softeners. We have bulk forming. We have osmotic and we have stimulant laxative. In this, we use always stimulant laxative. Okay. Most commonly used stimulant laxative is bisacodyl, otherwise known as dulcolax. Okay. Stimulant laxative counteracts the effect of morphine in the gut. Okay. Morphine will kind of paralyze the gut, decreases peristalsis, increases ring contraction, reduces fecal sensation in the rectum. All of this morphine does. But stimulant laxative will counteract, increase the peristaltic movement in the gut so that patient's constipation is relieved. Okay. If stimulant laxative alone is not working, you can increase the dose and you can add a stool softener like liquid paraffin. Okay. Stimulant laxative along with the stool softener can help in with patients with constipation due to morphine or an opioid. Okay. But stimulant laxative is mandatory. Okay. And this stimulant laxative, which is bisacodyl, should be continued as long as the patient is on morphine. You should stop stimulant laxative only when you stop morphine. Okay. A morphine without stimulant laxative, you can be 100% sure that the patient will get constipated. Okay, so morphine is always given along with stimulant laxative bisacodyl. There is one more side effect of morphine, which is opioid-induced nausea and vomiting. See, I said morphine, as long as the patient is on morphine, patient will have constipation. So stimulant laxative is given throughout the course to prevent constipation. But opioid-induced nausea vomiting is not like that. Okay, it is a transient side effect, which means it is only there on the first 3 days. Maximum 1 week. That also is very rare. First 3 days, patient may feel little nauseated. That is because your liver is learning to metabolize this new drug. Okay, it is you always seen in naive patients, opioid naive patients. First time they are getting opioid, first 3 days they may have some nausea and vomiting. So to suppress this nausea and vomiting, for first 3 days we give either haloperidol. Haloperidol means very small dose, 1.5 to 2.5. That too only once in the night. Okay. If you don't want to, haloperidol can be slightly sedating. So in elderly patients, you should be a little more careful because when they get up in the to go to the toilet in the middle of the night, because of the excessive sedation caused by haloperidol, they may fall. So in elderly patient, you can use metoclopramide. Metoclopramide, you need to give 3 times a day, morning, afternoon, and night. Just for 3 days. After 3 days, you can stop it. It is for patients who are opioid naive. Means first time they are getting opioid. Okay. You don't have to continue this antiemetic. After 3 days, you can stop. Then we have drowsiness. When you start the patient on morphine, drowsiness for the first 3 days can be normal. Okay. As I said, your body is learning to metabolize. So first 3 days it is normal. If it is persisting beyond 3 days, then you need to reduce the dose. That means you have overdosed the patient. The other very rare side effect is pruritus, itching. Okay, it's a very rare side effect. Okay, very rare. Okay, you can try with chlorpheniramine if the patient has itching. If chlorpheniramine is not working, ondansetron is one option. Ondansetron is your emesit. If ondansetron is not working, okay, then you may probably have to switch to another opioid. We have fentanyl, we have methadone. So other opioids can be a replacement for morphine, but it is a very rare side effect. I have not seen a patient with pruritus with oral morphine. Next, these are all side effects. Side effects can be managed, okay, by another drug or by dose titration. But toxic effect, when you see, you need to stop the drug. Okay, what are the toxic effects of morphine? Myoclonic jerks, just sudden muscle twitching, face muscle twitching, just one group of muscle just twitching. It could be a sign of morphine toxicity. Over drowsiness. Over drowsiness is difficult to arouse. You are not able to wake up the patient. Patient is in very deep sleep. He's only breathing. Or the breathing is very spaced. Respiratory rate is come down. Okay, close to 8 or less than 8. That is respiratory depression. Okay, over drowsiness. Hallucination and confusions. Okay. Morphine toxicity is not seen in common drug prescription of morphine. It is usually seen in patients with renal impairment. Okay. I said this earlier, morphine is excreted by the kidneys. When the kidneys are not working well, there is dose accumulation. Okay. So in that case, patients can have morphine toxic effects. Okay. Um, I remember there was one patient with CA cervix. Uh, Her illness progressed and she developed obstructive uropathy, which compromised her renal function. Creatinine was steadily increasing. She was on morphine for pain because at that time we didn't have any other opioids. So one replacement for patients with renal impairment will be methadone. Methadone is safe in patients with renal failure. But the problem is we didn't have methadone at that time. So we continued morphine, but we didn't give it every fourth hourly. I remember we first gave it 3 times a day. Even then, patient was slightly drowsy. Then we started giving it BD. With BD, morphine, she was comfortable because kidneys are not working. No, the drug is not getting eliminated, so it is getting retained. So with BD morphine, her pain, she was pain free at the same time she was not drowsy. So with that we could understand this is the level of dosage she requires. Okay, I am stopping here now. If you have any questions, we can take those questions. Um, um, is there any case presentation by the participants?
No, sir.
Okay. Any questions or doubts?
Hey, hi. Please feel free to ask.
I have few other things on how to manage bone pain, breakthrough pain, end of dose pain, but I thought as a basic overview, it may not be very needed. But if you want, I can teach those things. If not, I can stop. It's up to you. In the list of the things that were need to be discussed, I think I have covered those things.
Please tell, sir, there is one comment from Shik.
If you have any questions, we'll take those questions. If you have doubts, we'll take those doubts. Then let's see if we have time for other things. I have time
Yes,
till
sir. Till 1:30.
1:30. Okay.
Sir,
Yes.
there is one point in use of morphine. The last point was count the number of RD. What is that mean of RD?
Are these rescue dose?
Okay, okay, okay. Thank you, sir.
I said no, that 6 regular dose, 3 rescue dose, and how do you add it to the regular dose?
Yes,
So
sir. Understood.
every time patient takes rescue dose, tell them to write it in the diary so that you know what is the dose required by the patient per day.
Yes, sir. Understood. Thank you.
Is there any another questions or other doubts?
They are very silent.
Sir, where can we? I'll update on that website, means platform.
I will share the presentation with
Yeah,
Hannah. She
I'll
used to
update on platform. Yeah. So, can I take the silence as they don't have any doubts? Okay.
Yeah, they should say.
Okay.
Sir, I
Yes,
have doubt.
Yeah.
Can you briefly explain about the no ceiling effect? As I have understood, it means that as much the patient need, you can increase the dose. Is it right?
yes,
So that is the no ceiling effect.
yes, correct. The ceiling effect is patient's pain. That is the ceiling effect. If the patient's pain is not settled, see, there are, I didn't talk about neuropathic pain management. For example, there are situations where patient's pain may not go down, but increasing the dose of morphine will make the patient drowsy. Okay, I said you can increase the dose of morphine as much as the patient needs, which means as much as the patient has pain. Morphine will not do any damage to the patient. It will be used up for pain management. But there are certain types of pain where morphine can give only partial pain relief. One example is bone pain. The other example is neuropathic pain. Okay. What happens in neuropathic pain? Okay. Patient will say that he has pain. Okay. You increase the dose of morphine. Okay. Patient still says he has pain. Okay. You further increase the dose of morphine. Now the patient is little drowsy. You can visibly see it. But the patient still has pain, which means morphine is not working against this pain. It is working only partially. That is why he is having partial pain relief. This is what we call semi-resistance. Semi-resistance is partial resistance. Okay. It is not that the pain is not at all going away with morphine. It is only partially going away, which means the pain is getting conducted through different pathways where morphine is not working. Okay. That is one type of pain is neuropathic pain. Okay. So in neuropathic pain, you should continue morphine, but don't increase the dose beyond the patient is at the point where patient is drowsy. So along with morphine, you will have to give other drugs like amitriptyline, gabapentin to suppress the neuropathic pain. So combination of opioid with neuropathic agent will help. Similarly, for bone pain and headaches, okay, in that case, morphine will give only partial pain relief, okay, and patient still has pain, and you increase the dose. Now, patient is little drowsy, but pain is not going away. Now, patient has a pain where morphine doesn't fully relieve, okay. So, what you do, you give for bone pain, you give an NSAID. NSAID suppresses inflammatory bone pain. So patient will get good relief. Or you add other agents like bisphosphonates or radiation for bone pain is very, very helpful. So that is how we kind of titrate and understand. See, pain assessment is very, very important. Unless you have differentiated nociceptive pain, neuropathic pain, in nociceptive pain, bone pain, muscle pain. In muscle pain, morphine will not work at all. No matter how much morphine you give, patient will feel drowsy. Patient will sleep, but he will say he's in pain if you ask him. So for muscle pain, you'll have to give muscle relaxant.
Okay, sir. Understood, sir. Thank you, sir.
For a pure nociceptive pain, morphine will work like a champ.
Thank you, sir.
Is there any other doubts? So, can we wind up?
Yes.
Yeah. Thank you, sir. Thank you for the insightful session for us. So, participants, please share the feedback. I'll share that link on in that group. So please share your feedbacks. And I'll upload this PPT on our website, IECO web platform. Yeah. Okay. Thank you, sir.
Thank you. Bye.
Bye, sir.